On slide 3 of the general considerations. So on here, it's talking about all of the polymyosities, derm, immune mediated necrotizing myopathy, and heterogeneous group of rare autoimmune. We're talking about all of the things that would be causing some of the muscle damage. We would see of the elevations of the CK, of the AST, of the ALT. So we've got some of the lab abnormalities that are indicative of the myo issues there, of our muscles. Some of the things that we could see, which we're going to look at some of the pictures on there, is the heliotrope rash, or the Gatron sign of the papules that we can see of the dermatomyosites. Incidence of 1 case per 100K every year. This is happening when some individuals are between the ages of 40 up until 60. So 45 to 60 is what this is most often seen at. The dermatomyositis is typically distinguished from poly, and then that will produce us out with the rash that is out there. Muscle weakness, symmetrical of the proximal muscle weakness, evolving over the weeks to months. So yes, if it's the proximal groups, we're talking about the neck, pelvic, thigh, and shoulder muscles, which is symmetrical. So it's not just on one side, it's on of the both sides. When we're talking about the legs, that would be of the hip flexors that is most common with the symptoms. The low muscles, we're talking about the difficulty with repetitive movements more than of a single strength exercise. So it's the difficulties of the walking up a hill, upstairs, working with the arms above the shoulders, rising up from the chair. So it's just all of the movement. Gradual onset, but then it could go on and on and on with progression. The distal weakness should occur only in the presence of the proximal muscle weakness. If you're not having that, then we would have to get into the differential diagnosis of what's going on. Arthalgia, myalgia, arthritis, severe fatigue, the Raynaud phenomenon, red, white, and blue, right? It can also be present over there. Dyspnea, so we're having some of the diaphragmatic weakness, could also be causing some of the interstitial disease. Cutaneous, so the derm stuff. Gatron's papules, raised violaceous lesions on the extensor surfaces. Most common of the MCP, PIP, and of the DIP. Gatron's sign could also be some of the redness rash involving extensor surfaces. Heliotrope rash, red or purplish of dislocation, the coloration of the eyelids. We're going to see a picture of that next. Less specific rash, so of a shawl sign, that is erythematous rash on of the posterior neck and shoulder. We could also see one of the V signs, so it's on the anterior neck and shoulders. And then of the hiker's feet and mechanic's hands. When we see those pictures, it looks like mechanic's hands. And so those things. So let's go on to slide 6, and we will see that the heliotrope of the rash that is on of the eyelids. So she's got it, or she or he has that on that eye there. So it's of a reddish purple eruption. Next slide shows us of the heliotrope rash. We have seen some of the similar rash with the lupus the other day, but this one is different. As you can see, the heliotrope rash is on two of the spare or the nasolabial and of the eyelids, whereas lupus, it doesn't have that. There's of those papules. We talked about it, how it's most common seen on the MCP, of the DIP, and of the PIP areas. So we can see those of the papules. Next slide. On the left, we can see of the V sign, and then the other one is of the shawl sign. Next slide is the mechanic's hands. Looks like they are digging around in all of the vehicle's stuff that can tear them up. Next slide. Again, that is more of that non-lupus areas on the left, because we can see how it is on of the nasal labial and of the eyelids there. It's also some Gattons, because what we can see at those joints there on of the right side. Next slide. Again, of the Gattons. There's of the V-neck. So what's the diagnosis? What is of evaluation? So we would definitely, for the proof of what it is, we would have to do a diagnostic muscle of the biopsy. Proximal muscle of the weakness. So where is that at? And this is where we're going to do the biopsy. We already talked about if we're doing some of the labs that we are going to have of elevation of the CK, atolase, ACT, ALT, and LDH. Depending on of the abnormality, often varies during the disease course. One of the other things that can help us to establish this as of a diagnosis is for us to do of an EMG and have it be abnormal. And then also if they have the characteristic rash that we just seen in all of the pictures prior to this slide. Next slide. Again, for the diagnosis, we can get into some of the antibiotics, due to the fact that 20 up to 30% of the patients will have the anti-Jo1 antibodies. We'll also be seeing this with some of the interstitial lung disease. So we have of ILD, the Raynaud's, arthritis, and it's breaking it down into of the things that we have already gone over with. Anti-nuclear antibiotic, we can see how it's of a higher percentage that will make it positive. Next slide. Detailed H&P, so history and physical. What has this been like? What have you been having some symptoms, history? You know, what are some of the medical history stuff? CK, AST, ALT, LDH, GTT, aldolase, those are of the labs that we talked about. We also talked about the EMG, the MRI, and of the muscle biopsy that we will have to do that for this one. Inflammatory muscle disease treatment. Okay. The goals of the therapy include that we want to increase the strength. If anything is ever knocking down, we want to pick it back up, of course. Let's also control the pain. Let's improve their ADLs of how to get these things improved. Mainstay of therapy, it focuses on control of inflammation through the immunosuppression. What can we use? Well, the first line would be of the prednisone, 1 to 2 milligrams per day for 3 to 4 weeks, and then also the tapering slowly off. If it is prolonged up to 1 year, then we can do it more frequently. Then we'll also use some of the higher the dose tapers. Of course, like all of the side effect with steroids, we could have them having some myopathy. And if we're having some of the poor function, then of course we could use some other things. Some other things like these ones on the next slides. So if we're going to do what are the indicators for additional immunosuppressants, we'll have some of the patients. This thing just died too, so who cares? I'll be loud. So the patients are experiencing some of the complications for the long term. And we have an inability to taper these things off because of the fact that it can cause us to have the muscle weakness. If we've been doing this for 2 to 3 months and it's not working, then hey, that would mean for us to get into immuno stuff. Rapidly progressive disease with respiratory failure, then we need to get into it more if that is occurring. As we have talked about before, this would be of these medications here. So azathioprine, the methotrexate, rituximab, IVIG, and then the cyclos. But at the bottom is the most important part, so exercise, exercise, exercise. Just get all that strength back up again. Prognosis, it would be very poor.
Need a battery? Tech support, sorry. Tech support.
No, I'm talking loud. With the prognosis, right? So it could be dependent on the weakness of the extra of the muscular or of the response to therapy. If it's not working, then the prognosis is not as well. Also, if we're having some of the other the diagnostic things, then we could have an issue there. All right, on to the next one. Okay, let's go. So this last one is just talking about all of the biopsy, excision, everything that like y'all would start to do, and then get into the techniques of the follow-ups, of the treatments of the wounds, and all of that kind of stuff there. So let's start over on step number 4. So this can either be incisional or excisional, okay? Through all of these, the surgical stuff that y'all will be having inside of phase 1 as well as phase 2. If you're doing the family practice or some specialty stuff, do not incisional at all. Take every damn thing out. So excisional is the key, okay? Next slide is a picture of that there. Excisional, excisional, excisional. Do not incisional to leave something there. Next slide. Just talking about here what we will be going through. So a shave, that's almost as if you're using like of a razor, you know, to get that out. We'll have some pictures of that in here. We can also do the punch and then excisional. Next slide. So how do we do this? We will have to treat some of the pain. So we will use some anesthesia. Number 1 is of the lidocaine, right? So once you get that in there, it is only going to take about of the 2 minutes to have that in there, and it would last, you know, for up to 2 hours. There are some other ones which would be used mostly if we're doing this inside of a surgical aspect, or if there's something that would require more excision, like the cane, yes, okay, of the marking, okay? So that will then, it'll last hours after hours. Slow injection decreases that of the pain. If we need to use some of the vasoconstriction, then we can use some epinephrine. Again, avoid using in the ears, nose, penis, toes, and fingers, okay? Once you get some of the lidocaine into there, then we're gonna wait for some time to just make sure that it's all in there, and we're not gonna have a patient to punch us in our face because we're stabbed them. Instruments. So we have the staples, the needle drivers, skin hooks to move it on up, and then we have all of the different types of sutures. So here's some of the pictures of them there. Yes, it's got 10, 11, and 15. 15 is the one that we will be talking about over and over again, and we've already done that throughout the past lectures. And we can see how we clamp those into that. Y'all have seen some of this when it was the pig legs. I think that was last week or the week before that. So we just connect these things up, or we just use one of the ones that is just already connected. Next slide is the shave, right? So this is an easier one because of the fact that you won't have to have a technician there to hand you stuff, move them just back and forth. So we would still use some of the lidocaine, and then it's just to shave it to get that off. Along with the scabbles, we would have to have some of the other things to help us to lift up of the sutures, or to lift up the skin, to use those. So we've got several of the different ones. I'm not going to test you if you should use a Derf or a Collier, okay? I'm not going to do that because they all look like they're the same damn thing. Again, here's some breakdown. Oftentimes we will use these to lift up of the skin out of the area. If we're going to cut something, we could lift it up here with that one there. Some of these, I would say, not inside of a primary clinic. They would be used in the surgical All right, so let's talk specifically all about the shave. We're on slide 15. So what's the purpose? The purpose is to get the tissue so that we remove it, but then also send it out for the pathological evidence. Shave biopsy, we will most commonly use that for the SKs, for the warts, and benign appearing the nevi. For raised of the lesions, when the full thickness tissue specimen, it's not necessary, but it could be one of the options if we don't have anything else. Mark of the lesion prior to the anesthesia, right? So we're going to go up and around that, and then up and under, so that we can take that off. Insert the needle into the dermis and infiltrate with the anesthesia to raise the wheal. I talked about earlier how we have pretty much said the number 15 over and over with every single of the lesions prior to this. So the 15 blade, we can use the derma blade, which is what we just saw the picture of, and then of a razor, right? So if we were to use those things. Definitely want to hold that of parallel, so it's not like we're going to go down from of a vertical aspect. It's more so just to go parallel there. We'll be using this with our right or left hand, which is our dominant one, and then we use of the other one to have stability and the traction, so that the shave is working. Next slide. Lesion that would be suspicious for a melanoma. Shave does not give us of the full thickness, so we're not going to use it. If we see it and we know that it is of a benign, then yes, we could use of the shave. But if we think that, no bueno, do not use it. And why? Because of what it says right there. We need to determine the thickness. So Breslow and of the Clark level. Advantages. It's quick. Sutures are not needed. An assistant or a technician will not have to be there with you, so you can do it all by your lonesome self. It's clean. The site is not difficult, and the wound care is easy to restrict, and all of the patient education of how it is going to work. Disadvantages. You could have some of the hypopigmentation, so it could look like a white spot of the skin. You could have a larger scar. And as we said before, this is just shaving it top, so it's not able to get all of the full thickness that we would have to go all the way down to dermis. Then that would not work. Like we talked, the complication scar, hypopigmentation, erythema, regrowth if it's not all taken off. And it's rare that you could have a infection, but everything could always occur. So that's how it looks. We've got a raised of a SK of warty. So we're going to numb that up. Then afterwards, as a C, that is of your non-dominant hand, to put some of the traction on there. Oftentimes it will just raise it up a little bit. Then the blade is going to go up and up, under, parallel, to remove that lesion. I said earlier how if it is pedunculated, then we could, instead of the blade, we could just use some of the scissors to lift it up and to cut it off. All right, so that is all of the shave. Now let's get into the punch. So going now on to slide 24. Punch biopsy, that is what we could use if we need the full thickness of the specimen. For most of the superficial inflammatory and bullous disease, benign and malignant of the tumors, except for of a melanoma. So if you do know that it is benign, then yes, you could do the punch biopsy. But if you have any suspicion of it being of a melanoma, then don't punch it. Kill it. There are the differences of the signs. So you can see the 2 to 8, which will be shown on of the actual device in and of itself. You will know what it is that you need depending on the size of the lesion. Slide 26. So how will we do it? First, we're going to be doing some of the lidocaine there, and it's going to be going all the way down to the dermis. So it's not just of a shave that's up and under. This will go all the way down into there. We always wait for some time to just make sure that it's good to go. Same thing as with the shave. It's of the non-dominant hand that will provide us with the traction to get that there. Penetrate completely through of the dermis, so it's pushing it all the way down, and it twists just back and forth as you're doing that. So we want to see the fat. So there it is. It's pushed all the way down. Then we just pick up all of the biopsy that is in the middle, and then we chop it out. Another picture there. But let's look at some real ones. So go to slide 29 and you can see where that spot is at. We then use the biopsy on the third picture of the upper right. You can see how now that is the area that we'll want to lift up and out with our to lift it out and then to cut it off, and then that is the last one, excuse me, that is over there. Contraindications of the punch on slide 30 is talking about we have to be important that we do not have any of the arteries and nerves that are in that area, because we don't want to bleed them out or have them lose sensation in that area. This is also contraindicated for the hand, of the dorsum, of the face, of the neck, of the volar wrist, etc. So where those of the locations are at, we would not want to do that there. Next slide is talking about advantages. So we can definitely, if we're going all the way down to the subcutaneous fat, we'll get all of the full of the thickness. Better looking pretty, so cosmetic, faster healing, easy to use, relatively inexpensive. So we're just gonna punch that and pull it out. Disadvantages you can have of a hypertrophic scar, unless we use all of the sub-Q suture and the stair strips, and you don't need them to come back and discuss the path. That would be of a disadvantage. If they need to come back, no bueno, they won't be happy. Again, some of the complications. You would have some induration, erythema, hypertrophic scar, excessive protruding at skin and edges. Bleeding and infection are rare, but like everything else, it could happen. And it's talking about there the dog ears. That's if you leave some of the skin that is outside of it, then it just flops around and it doesn't look good. Circular punch of an oval defect there. We can also just use it for the nails. So if we're thinking that there's something up and under the nail, we don't want to remove that entire nail, but it can be just punched to get that area out. All right. Next up, onto slide 37, we're getting into excisional. So if it is deep, if we think that it is a melanoma, then we would have to do these things. If it is of a BCC or of an SCC, this would be of the things for us to do, right? When we start this up, it's marking it off. It's drawing out some of the locations for us to do that. So yeah, basically draw a football, but we're gonna see that here in a bit. So pre-op, are they having any of the allergies? Are they having some bleeding tendencies? So if anybody is having any type of a surgery, we're always informed, hey, don't be taking any NSAIDs or some aspirin, some anticoagulants, because then the bleed will be extensive. Use of alcohol, tobacco, infection with HIV or hepatitis, tenderness towards an abdomen wound, so keloid or of some scarring. These are the things that we need to know or to instruct of a patient to do or not to do. That is the question. Okay. So the techniques here, we need determine the relaxed skin of the tension lines or natural wrinkle lines of the skin, because we want to place incision to parallel or fit within of the lines. So we don't want to go against those lines, we want to go with those lines. A biopsy, it will, yes, if the lesion is the size of a dime, we're still going to cut outside of that if it's like a dime and a half. So we need to have a margin of the normal skin to be of the 2 millimeters outside of that. Slide number 40 is talking about ellipse. I was saying that as if it is of a football, right? So it's outside ellipse. Length should be 3 times the width. Longer is okay. Why longer is because of the suturing. We're just going to push that back together. So the length of it, who cares? But if it is of the width, then it's just going to pull it apart more. So then it will be harder to put it back together. The dog ears, we talked about that a little bit, and if we go to the next slide, you can see of the dog ears of the 2 all the way on the bottom. So you can see how there's extra of the skin that is just outside of there, and so those are what that is. Top to the right, you can see what is correct. Why is it correct? Because it's more important on of the width. So you can see of the dark lesion, and of the width is just of the 2 millimeters outside of that as far as the width goes. The length, it doesn't matter. You're still going to be suturing it. So the dominant hand is holding onto the scalpel, whereas the non-dominant hand is providing you some of the tension there as you're going to do this. Next slide is showing you what that is. Does it look like it's good, or it looks like it's a little bit off? Both. I mean, when you can see the lesion cut out, that of the width is on point. What it looks like over there doesn't look like it's all that close, but again, this is of a picture, and we can't actually tell like how close or far away it is. And again, I know that some of y'all had this experience with the pig feet, and we talked about that it was hard to tie it back up. So remember that the width is more important. There's another one. So it's all excised, and then lifting it up, chopping it off, and off to the lab it goes. I just talked about this when I was talking about the pictures. So we're going to be using some lidocaine or some Marcaine. Wait after that, just to make sure that we have all of the vasoconstriction and of the numbness. Hold the scalpel perpendicular. Traction with the other hand. Belly of the blade. Depth of excision is all the way down to the sub-Q fat. So we're taking all of the dermis out. Elevate width of the forceps and snip with scissors or of the scalpel blade. So we're going to use those of the forceps to lift it up and out, either to cut it or chop it off with the blade. Closure. 1 to 2 of the layers of suture, right? So you're going to use the first layer and the second one. Subcutaneous to decrease the tension across the wound and close all of the dead space. Second layer is of icular the suture, so a better approximation of the top side, just to put those skin together. We do not always have to use the 2 layers. We can use just the second if it's not super deep. If it is deep, then we are going to put some of that on the lower aspect. Complications: we can get a scar, we can have infection, we can have excessive the bleeding because we're not having any of the hemostasis. There can also be some of the nerve damage, especially if this is on the head and of the neck, because we have all of our nerves flowing through that area. Closures. So we can do of a simple interrupted, right? So we will see some of the pictures of that here in a bit. But we can also do of the subcuticular aspect to just help with all of the tension. So here it's just talking about what we were with of the first layer and of the second layer. You can see this is of the first layer, so it's all the way down to sub-Q, and it's just tying that together, and then the second layer is just up top, and it's to connect those there. I'm sure that y'all have already been taught all of these stuff with the surgical course. If it's running of a closure, then it's just in and out, down the way to go. That is what they look like. Wound care. So we need to be treating them to prevent contamination, right? So we're going to wrap it up. We're going to use some of the topical antibiotic stuff and to just hold it to its own. Immobilize the wound. So we're not going to be having them to jump, run, or dive. Moist covering. We're going to avoid some sunlight during the healing process. What are we going to tell them? We're going to say, okay, well, keep it bandaged for the 24 hours and keep the area dry. After we remove that, then we would have to cleanse of the wound with the soap and water. The topical antibiotics, ointments, twice daily, and cover it up. Do not go into the hot tubs, salt water, which that would hurt us, bad. Or any of the other environments where you could be exposed to some of the negativity. Slide 53, again, the Tylenol is safe, but we're not going to be using the aspirin or the NSAIDs because then we could have that occurring. If you do have some of the bleeding, then apply some of the firm of the pressure. And keep that on there for about 20 minutes just so to stop the bleeding. it's not working, go find an ER. Three to 5 days after surgery, if there is infection, that is when it would probably pop up. If it's already been of the times longer than that and you are not symptomatic, then you are good to go. We will have them to come back if we need them to do some of the suture removal, or if we need to just look at the wound again, then that would be one of the reason. As I said a little while ago, we will be letting them know not to go out and play basketball. Don't go diving, running, doing things that could cause them to have more of the scarring, of the keloids, of abnormalities that would be there. Slide 55, these are the type of the sutures, okay? So we have the vicryl, the monocryl, okay? If it ends in CRYL, it is absorbable, so you don't have to remove those things. It will just fly off into the future by itself, okay? So it's going to disappear. We have specific of the sizes, types, material, specifically are all different regards to the scalp, eyelid, face, neck, and trunk. So you might know what to ask your technicians for depending on where you're going to do this at. So if I'm going to do it on the face, then I'm going to ask for 4 to 5 monocryl, yada yada. So know what you want to use. Now here's some pictures of just what they are. So this one is of a simple interrupted. What does that look like? Slide 57. Staples, okay? We did not speak about the staples, but that is what they look like. Again, what do we think this one is? Simple of interrupted, right? So this is just patching it back together before and after pictures. Next slide, this is of a horizontal of a mattress. So this is just going back and it's horizontal. Same thing, that is of a horizontal, as opposed to slide 61, that is of a vertical mattress. Mr. Booth had a video on here, but it's not working, nor can we watch it together at the exact same time because it's not on the projection. All right, so that is the end of today's lecture. 11 o'clock, so you will have a longer lunch because I know that you've got 2 more this afternoon, right? Okay, I will be seeing y'all on Wednesday at noon on the big blue button, and I'll go through